Welcome to the American Shoulder and Elbow Surgeons podcast. I'm your host, Peter Chalmers, a shoulder and elbow surgeon at the University of Utah. Before we get started, I should have mentioned the views expressed in the podcast do not necessarily reflect the views of the American Shoulder and Elbow Surgeons Society or the University of Utah or the institutions of any of our guests. Today, we're very excited to invite Dr. Thibault Lafosse to the podcast as our guest. Thibault is at the Alpes Surgical Institute in Annecy, France. He's also the director of the Annecy Live Surgery Meeting. Thibault is trained in both hand and shoulder and elbow surgery and is well known for his innovative and minimally invasive approaches to complex shoulder problems that he sees in France. Welcome to the podcast, Thibault.
Thank you, Peter. Thank you for having me. It's a great honor to participate to that podcast.
Now, I know you've just recently finished the Annecy Live Surgery course. How did it go?
Yeah, it went very well. Thank you. It was actually a little more than a week ago, last day, and everything went well. First, most important thing is that I got the opportunity to review all the patients that we operated during those 3 days of live surgery with a week of follow-up, and they're all well. Of course, it's not a long follow-up yet, but we don't have any complications. Patients are well, no major hematoma, no infection, no fracture, everything so far so good. So that's the most important thing. Patients were very happy and grateful also to have benefited from the expertise of the surgeons that were here invited as faculty. So
what do you?
So far, really.
So and these are all your patients from your practice?
Absolutely, yes. Except 2 of them, which were who were brought by my partners. But 33 patients were my patients from my clinic, from my practice.
So how many total live surgeries did you do then?
35.
Holy smokes, what an effort.
It requires a lot of organization. We're getting quite good at this because we basically work in advance, and we start preparing the Congress 2 years in advance. So I just got out of a meeting to organize the agenda of 2027 edition, so in 2 years. And so there's a big organization, but we're ahead of it, and it runs quite smoothly every time.
Maybe can you give us what were some of your favorite technical tricks that you learned this year watching all those people operate?
So very interesting. It's funny because I got the opportunity to assist Dr. Lutzinger from Switzerland. He's responsible for my motivation to become an orthopedic surgeon because he operated on my knee when I was 17, and I really had a great interaction with him. He's a great guy, and I operated with him this year on a rotator cuff, and he taught me a lot of tips and tricks, such as triple row for rotator cuffs, something I'm really not used to doing. And he explained how it helps to distribute the load on the sutures and the anchors using triple row. It doesn't necessarily require to use more anchors, actually. It just put one medial, one intermediate, and one lateral. And I really like that. So that was really interesting. It's also always very interesting to operate with Bassem. We shared a couple of tips and tricks regarding the fixation of the pec major transfer for deltoid palsy on the clavicle. Just simple things, but useful with the buttons and cowridge knots, things like that. And
those all sound like useful ones. It certainly they all sound like complex cases too. It sounds like, if you were doing a pec transfer, I know Eric Wagner did a shoulder fusion. These are not simple, straightforward cases.
Yes, so this is basically maybe something that's changing with the years of the Annecy Live Surgery Meeting. My practice is really a lot about combining my expertise in peripheral nerve, microsurgery, and shoulder. So I have a lot of patients who have shoulder sequelae is from brachial plexus injuries, so we have to deal with fusions or with TEM transfers. I also do a lot of thoracic outlet syndrome, so I can either do an endoscopic brachial plexus exploration and release, or rib resection, and along with those neurological aspects of the shoulder come some complex patients with deformities. And so it was interesting because there were two fusions, planohumeral fusions at the course, one for brachial plexus sequelae and the other one for complex dysplasia of the shoulder. So two different indications, two different ways of doing it, one with Eric and one with George Athwal. I also learned very much from both of them, their tips and tricks. I totally do it differently than they do, but it was interesting to see them doing it and to do it with them.
Well, I wanted to talk to you about this because I think we all see a small number of these patients, but it's really useful to get the knowledge of someone who does a lot of this. So let's start maybe with the spinal accessory nerve. Tell us your general approach to the palsy here. What are you more on the Eden Lang side, more on the triple transfer side? Are you doing decompressions? Tell us about that.
Okay, so question is about how to manage a spinal accessory nerve palsy, correct?
Correct. Yeah.
Oh, yes. Because there's kind of more to it. If you also speak about brachial plexus injuries, you know that spinal accessory nerve transfer to the suprascapular nerve is a gold standard. And with the years, I've become more and more used to not using the spinal accessory nerve anymore, and to prefer either do nothing and preserve the trapezius for a better function with a secondary procedure, such as palliative with a glenohumeral fusion or lower trap transfer. And I use the C7 fascicles to renervate the spinal accessory, the suprascapular nerve. So this goes into a global perspective around the spinal accessory nerve that to me needs to be preserved because the function of the trapezius is so important for the overall shoulder. And so for me, there are always steps when you want to manage a palsy. There's always some room for spontaneous recovery first. So wait and see can be interesting, but not too long. And then in some situation, when there's room for release, exploration of the nerve and nerve release, it's also very interesting. And next step is, of course, nerve transfer. And for a spinal accessory nerve, when feasible, for example, in a iatrogenic injury at the neck, I like to do a C7 or C5 fascicle nerve transfer to the spinal accessory nerve. And of course, if nothing else, then palliative surgery is feasible, then I will do 3 muscle transfers the way Ella-san described it. And of course, the scapulothoracic fusion down the road.
Have you found? Tell us the timeline for those. Like when is the nerve transfer the right answer for you versus the muscle transfer?
Honestly, when you're 100% sure that the nerve transfer is required, the earlier the better. We usually say 6 months, but if you know there's a lesion and you're aware of it just because it was reported during the previous surgery while it was injured, or because you know that there was a wound and the palsy is secondary to the wound, so you're 100% sure that there's a lesion, don't wait too long. The only thing that matters when you want to wait a little bit is if you consider there's a chance of spontaneous recovery. If you have a chance of spontaneous recovery, the more a nerve recovers spontaneously, the better the function down the road will be, because you can never restore as a good function as a spontaneous recovery. But if the spontaneous recovery doesn't happen, then you shouldn't have waited too long. So I would put this simple, saying, if you know there's a lesion, don't wait. Go ahead and operate. And if you are not sure there's a lesion, but you see that the recovery is slow, don't wait more than 6 months. And after 6 months, I consider that it's going to be too late, particularly for a big muscle like the trapezius. So after 6 months, I'll discuss with the patient, but I'll probably go for a true muscle transfer.
What about the long thoracic nerve? Is your approach here similar?
Yes, it is. However, the long thoracic nerve is a bit more tricky because it's involved into many other kind of pathologies than simple situations such as a iatrogenic injury. Long thoracic nerve is very often involved in Parsonage and Turner syndromes or hourglass-like syndrome injuries, and these are situations where it's difficult to decide whether you should go to surgery or not. Because if you talk to a neurologist, a lot of them will tell you that a Parsonage and Turner or an hourglass-like syndrome can recover up to 2 or 3 years after the initial symptoms. So this makes the decision-making process a bit more complex. However, um, I do believe into neurolysis for the long thoracic nerve a lot. I have a lot of experience with performing neurolysis of the long thoracic nerve. I just do it a bit different than some other people do because I like to do it bifocal. I uh, I do an approach at the neck and an approach at the thorax because you can really release the nerve from the roots all the way down to its entry point in the muscle. So that allows to make a very thorough release. So that's my approach to the long thoracic nerve. I do a bifocal release of it.
And then if there's no hope of recovery, for you, the PEC transfer, is that a direct transfer or an indirect transfer? Is it a split transfer? What's your preferred technique there?
So it's a technique I really like because it's a very efficient transfer, really, really efficient. And my technique is using the sternal head with a direct transfer to the scapula. I harvest some bone at the insertion of the pec, and then I transfer it to the scapula.
Oh, I love that transfer with a little piece of bone. That I think,
Hmm.
as we know, that transfer is that's one of the best transfers we have around the scapula. Tell us about
Agreed.
the dorsal scapular nerve. Have you done any dorsal scapular nerve decompressions or nerve transfers?
So I have done decompressions in the setting of brachial plexus injuries, traction injuries with spontaneous recovery, and recovery around the trapezius and the rhomboids that was taking a little more time, and I wanted to explore the situation, or in the setting as well as Parsonage and Turner. And it's a nerve that is really close to the long thoracic nerve. Most of the time, it's easy to find it around the middle scalene muscle. So sometimes it's difficult to know exactly anatomically wise which nerve is which. So I use the electric stimulation to determine perfectly which nerve is which, and I decompress it with fair results. I'm very selective with the indications of neurolysis. So when I do neurolysis, it's because I really have the feeling that it's going to help. If I don't believe neurolysis can help, I go straight to a to a nerve transfer or to a muscle transfer. But regarding nerve transfer to the dorsal scapular nerve, I don't have any experience into doing that. Although it should work, there's no reason why. However, I have used this nerve to transfer it to the suprascapular nerve instead of transferring the spinal accessory nerve with fair results. Not as good as when we do a transfer from the C7 root and the middle trunk because we can take more fascicles, but it's a transfer that's interesting. So to answer perfectly your question, um, if I have a palsy of the dorsal scapular nerve, most of the time it's either not bothering the patient enough to do anything, or if it is, it's combined with another major muscle palsy. And the best solution to me is the scapulothoracic fusion.
So I was going to ask that. So if you were to see combined dorsal scapular spinal accessory nerve palsies, you would say a fusion is your preferred treatment in that situation.
Yes, I would. Although there is and actually we operated on a patient exactly like that during the last edition of the NC Life Surgery meeting. Um, specific situation, but FHSD patient with no rhomboid levator and trapezius, and patient was not motivated for a scapulothoracic fusion, although it would have been the best indication. So I proposed to do a right to left scapular tethering for that patient, which is a surgery which isn't that invasive. It doesn't blow any bridges, and the worst scenario is that it may not be very efficient. But actually, for that patient specifically, she was perfectly relieved and had an immediate post-op better positioning of her scapula with less pain in the back. So I think there's room sometimes for less invasive procedures, such as right to left scapular tethering, and not as invasive as scapulothoracic fusion.
I had some questions about the tether because I think that's a very interesting idea, and certainly I agree with you, way less invasive. When you do that, does it ever compromise the other scapula? I mean, it seems like you're putting the weight of both arms on the periscapular muscles of one arm.
Yeah. So I've never experienced any compromising of the other scapula, basically, because I guess that patients are so relieved on the site that they're suffering from that it compensates their overall function of the upper limbs so much that they don't complain from feeling, I don't know, bothered with the other shoulder.
Are you doing any tendon transfers for FSHD? Or is it kind of like the tether or the fusion are your two preferred treatments there?
No, I do sometimes. The only tricky part of tendon transfers with FHSD is that you're never sure that the muscles you're transferring are not going to be affected by the FHSD later on. So it
Mhm.
either has to be perfectly stabilized and you're sure 100% it's stable, and then you can go ahead and do some tendon transfers. But I think I always talk about that with the patient, and I inform them that there's the risk, but maybe they'll be better for 5 years. And after 5 years, if there's an evolution of their pathology, well, it doesn't blow bridges to do 10 transfers, and there's still the possibility to do a fusion.
Speaking of stability here, are you doing any scapulopexies, and when are you doing that?
So I've done quite a few, um, some of which had fantastic results, and some of which failed after a couple of months. And
Mhm.
I think that the reason for this procedure to fail is not related to the technique itself. It's related to the indications, and it's very difficult to those patients with scapulothoracic abnormal motion are very difficult to understand. Some of them have functional neurologic problems, and which I would explain as it is, but very well explained by Bassem El Hassan. There are patients with perfectly functioning muscles. If you examine at every muscle individually, they function perfectly. However, they can't work together anymore for some reason that is sometimes difficult to explain. So I guess that the scapulopexy that I did that didn't work were situations where the scapulothoracic abnormal motion was too evolved, and there were so many muscles involved in an imbalance that was so important that just the scapulopexy was not enough.
Now, you mentioned earlier you also care for a lot of thoracic outlet syndrome patients. I care for some of these patients in my practice, and they
Hmm.
can be a real diagnostic challenge. Maybe give us real
Absolutely.
quickly your preferred method for confirming a patient actually has this diagnosis.
So we're currently working on a publication that will hopefully come out soon, which is describing my algorithm for treatment for those patients, because So, as we said before, I have several tools to manage those pathologies with the endoscopic brachial plexus release, rib resection, scalenectomy. Basically, what's important again here is to select the correct procedure with the right indication. So, I would start with the easy part. It's easy when you have a documented neurologic vascular involvement. If you have an objective palsy, most of the time being on the lower trunk with a hand palsy, an atrophy in the hand, that's for me a no debate. It's an indication for surgery, open surgery. You need to go and check the brachial plexus. You need to decompress everything. You need to make sure that there's a good quality on the lower trunk. So that's open surgery release. And if I do an open surgery, regardless the situation, rib, cervical rib, hypertrophic transverse cervical process, hypertrophic scalene muscles, regardless the situation anatomically wise, if I go there and I open the neck to release the area, I will go uh, all in. So I will take down the rib, I will take down the scalene muscles, I will do everything I can to make sure that I don't go back in a few years because of a recurrence. And I also systematically do a pec minor release when I do those. So those are the easy situation, objective neurologic problems, vascular involvement, and either venous or arterial. And the tougher situations are where you don't have any objectivity on the neurological symptoms, and it's what we call subjective thoracic outlet syndromes, where you have patients complaining from pain and from neurological symptoms that you can reproduce with your clinical exam. So they really have something, although their EMG and the rest of their paraclinical examination is normal. Well, those patients are the one to which I do an endoscopic release. And it's even easier for those if they have a mild scapulothoracic abnormal motion and you have the feeling that they have a tight pec minor in the front. So those are the perfect indication for endoscopic release. But between those two entities where it's easy, straightforward that you're going to go for open surgery, and it's easy, straightforward that you're going to go for endoscopic release, there's everything in the middle that's like, in a shade of gray, right? And it's difficult to determine exactly where you want to go. So for those, the only solution I have is to maybe help my decision-making process with Botox injections, try to do the rehabilitation as much as I can, talk with the patient, explain them everything they need to know about the surgery and to determine their motivation,
Certainly, that's really valuable to hear. I, like you, have struggled because the endoscopic approach is definitely lower risk and it's a easier recovery for the patient than a rib resection. So I think it can be easy. I think sometimes for patients to convince themselves it will be enough, but it's an incomplete decompression if there are problems
Yeah.
with the rib and the scalenes.
Yes, absolutely. Well, I now go all the way up to the neck and I can do a scalenectomy endoscopically. I do a scalenotomy to be proper, using the proper terms. I don't do a scalenectomy endoscopically. I just cut the muscle, and you can sometimes when it's really tight, you can see it retracting right after you cut it. But it requires dissecting the subclavicular artery endoscopically, and it means that if you have a problem endoscopically, you have to be ready to convert and open the neck and manage the bleeding if there is. But yeah, it's a thorough decompression, but it's never as thorough as if you do a rib resection, of course.
Now, we've had a lot of back and forth between the United States and some of our European colleagues about posterior superior rotator cuff tears. Traditionally, the latissimus has worked quite well. There's some biomechanical evidence it's better for external rotation and abduction. Obviously, the lower trapezius is becoming the dominant treatment algorithm, at least in our continent. And there's biomechanical evidence that it has better line of pull and that it fires in phase and that it may be better, at least in adduction. What's your preferred transfer there?
So again, we published our algorithm recently, the one that helps to decide between lower trap and latissimus. And to make it simple, my algorithm is completely based on what we do for obstetric brachial plexus palsy sequelae. And to make it short, if there's a lack of active external rotation with the arm at the body in adduction, I would do a lower trap. But if the patient is more bothered by a deficit of external rotation in abduction, so ER2, I would rather do a latissimus dorsi.
Tell us about the front for irreparable subscapularis tear. Are you on the pec transfer side, on the latissimus transfer side, or is that also something where it depends on the patient's presentation?
So 0% of my non-repairable subscaps are managed with pec transfers. I don't do that ever. So for a long time, I used to do latissimus dorsi transfers only. And I recently came up after discussing with Bassem with a new transfer using the lower trap that we pass through the scapula. And we do a transscapular lower trap transfer. So using an allograft, we pass this allograft along the subscapularis fossa and connect it to the lower trapezius through a window just below the spine. And we showed that live during the anti-live surgery, and I did a couple also live during courses in the Alp Surgery Institute. And we recently published the technique. It's really, really nice. It's an easy transfer. Actually, I find it a lot easier than the latissimus dorsi transfer to the subscap. And it just requires some caution when you're moving medially because you don't want to damage the brachial plexus. But basically, if you really follow the subscapularis fossa and you're in contact with the scapula at all time, you're really safe and away from the plexus and the vessels.
So when you do that, it's an arthroscopic approach in the front and an open approach in the back?
Absolutely, yeah. Arthroscopic approach in the front, then open approach in the back, of course, to harvest the lower trap to manage the little window through the scapula, and then you just use a shuttle relay to shuttle your grafts to the lesser tuberosity, attach it there as if you would repair a subscap, and then use the other distal part of your graft to do a pulver-tap suture with the lower trap.
Now, it sounds like, I'm just envisioning in my head, the line of pull for that would be much better than the latissimus, because that's right in line with the subscapularis.
Yeah. The only maybe bad thing we could say about this is that it seems a bit more obvious to perform external rotation using, when you bring your two scapulas to the back, it goes along with external rotation more than it would with internal rotation. However, my experience with the patients I've operated with this technique, it's been 2 years now since I've done it for the first time, is that patients are really happy, and it's very easy for them to remember that they want to go in forward elevation or internal rotation. They need to get their shoulders closed to fire their lower trap, and it really stabilizes. It's basically a stabilizer. It's replacing the function of the subscapularis, which is bringing the humeral head more into the center.
So maybe the rehab is slightly more complicated than lower trap for the back, but it sounds very doable.
It is completely doable. I think it's really a nice alternative. So I'm working more now on an algorithm to decide whether I should do a lower trap or a latissimus dorsi for anterior cuff deficiency. And I'm not there yet because I don't have enough follow-up and enough experience. It's only been 2 years since I've been using this transfer. But basically, I would say that if the subscap lesion is isolated to the subscap and you still have a good supraspinatus, so it's really an anterior cuff deficiency, then I would go for the transscapular lower trap. Whereas if you have a combination of upper subscap and anterior supraspinatus, then you would want something more anterior superior to transfer, and then the latissimus dorsi is my favorite choice.
Well, I want to be respectful of your time because I know you've got other meetings today. It's just been incredible for me to talk with you about all these different nerve palsies and your experience, and it's been really valuable for the listeners who may see these things infrequently to hear about your approach. Certainly, I just really admire, the complexity and creativity that you bring here. So a big thank you for being our guest. And for all our shoulder episodes out there, don't forget to subscribe, and we will see you next time.